So now we are going to look at a management strategy for a common problem which we encounter in emergency rooms and to some extent in intensive care, bleeding from the gastrointestinal tract. Let's start with a case scenario of a 42-year-old male patient who is brought to the hospital with 2 to 3 episodes of hematemesis. He also gives history that he's been feeling weak for the last 5 to 6 days and has passed black colored stools for 2 days. He doesn't have any significant past medical history, but has had an excessive history of excessive alcohol intake for more than 10 years. He doesn't smoke or take non-steroidal anti-inflammatory drugs. On evaluation, this patient is anxious, he is pale, he is sweating and has a tachycardia of 116 per minute with a blood pressure of 90 over 50 millimeters of mercury. He has a mild pedal edema and his heart sounds are dual with no murmurs. Respiratory system wise, he has a respiratory rate of 18 per minute and is saturating 93% on air. His chest appears to be otherwise clinically clear. Abdomen wise, this patient has an ascites and splenomegaly and is not icteric at this point of time. He is alert and oriented. So what this means is we have a patient who has passed dark tarry stools, has vomited blood and has history of alcohol intake with ascites and splenomegaly, which probably points towards an etiology of a chronic liver disease with portal hypertension and variceal bleed. So the emergency room physician inserts a nasogastric tube which reveals a coffee ground aspirate of around 300 ml. The routine lab tests on this patient shows a hemoglobin of 6.8 grams, hematocrit of 19%, a white cell count of 12,000 and an INR of 1.1 with a prothrombin time of 14. His platelet count is normal at 1.5 lakhs and the bilirubin is 2.5 milligrams per liter and creatinine is upper limit of normal at 1.2 milligrams per deciliter. So this obviously seems to be an upper GI bleed, which by definition is a bleeding from source that is proximal to the ligament of Treats. Lower gastrointestinal bleeding is a bleeding from a source that is distal to the ligament of Treats and involves the small intestine or the colon. So that's the anatomical description of the ligament of Treats, where you find that most of the structures that are supplied by the celiac axis are part of the upper gastrointestinal tract. So the esophagus, the upper part of the stomach, the entire stomach and the upper part of the duodenum will form the structures which are proximal to the ligament of Treats.